joined, you can start.
Okay. Good afternoon, everyone. Myself, Dr. Ajay Rana, working as an assistant professor in Balok Department of Srimati Urmila Devi Ayurvedic Medical College of Health Sciences and Hospital, Hoshiarpur, welcomes you all on another day of webinar series. First of all, I would like to thank our Honorable Chairman, Sir, Engineer Amarjit Singh Walia, Sir, for the continuous support for the ongoing webinar of Ayush Vibodhini. Next, I would like to thank our principal, ma'am, Dr. Nakshinath, and our vice principal, Dr. Mridu Sharma, and all the rest of the faculty members for their continuous support and their efforts in making this webinar series possible. And in the last, I also welcome the students who have joined for the webinar. Now, I would request our vice principal, ma'am, to share few words. Over to you, ma'am.
Thank you, sir. Good afternoon, all of you. Myself, Dr. Mridu Sharma, Vice Principal of Srimati Urmila Devi Ayurvedic College. I deem it a great honor and privilege to propose welcome on this memorable occasion. Let me first of all start by giving the glory to the Almighty God for making this series Ayush Vibodhini a resounding success. First and foremost, I would like to thank our special guest, Dr. Ravi Sharma sir, who despite his busy schedule has found time to grace this webinar. And I also express my heartfelt thanks to our principal, Dr. Meenakshi Nath, for their valuable contribution towards this series. We are grateful to our chairman, Engineer Amarjit Singh Walia sir, for their continuous encouragement, and his able of guidance has always encouraged us. Now, I would like to thank wholeheartedly our brilliant and truly outstanding keynote speaker, Dr. Ravi Sharma sir. Srimati Urmila Devi Ayurvedic College wishes a warm welcome to you, sir. It's an honor itself to have you here, sir. There's a lot to say, but I will just summarize it in a line that you are truly an inspiration, especially for me, both personally and professionally. Thank you very much, sir, for sparing your valuable time. Over to you, sir. Ajay, sir.
Yes. Like ma'am said, sir is very encouraging and is a well-known personality. So before moving forward, I would like to introduce our guest speaker, Dr. Ravi Sharma sir. Sir is a well-known personality because he is treating more than around 100 patients per day, pediatric patients in a regional hospital, Una. And I have seen it. I myself have seen that sir is always surrounded by number of patients. It's our honor to have you, sir. Sir has completed his M.B.B.S from IGMC Shimla and also completed his post-graduation in 2004 from IGMC Shimla. After that, sir has been senior resident for 3 years from 2005 to 2008. And after that, he served at the post of assistant professor in Tanda Medical College and also as a post of assistant professor in Dr. Y.S. Parmar Medical College, Nahan. Sir has attended more than 50 CMEs and he has also been invited as a guest speaker in various CMEs and health science. Sir took the initiative and started the first blood transfusion in neonatal jaundice at the Regional Hospital Center, Una. Presently, sir is working as a pediatrician at the working as a pediatrician at the regional hospital in district Una, and he is also in charge of special newborn care unit at the regional hospital Una, for which he was awarded by the Himachal government for their SNCU responsibilities. Now I would request sir to start today's lecture with the words. Over to you, sir.
Thank you, Dr. Ajay. Thank you, Dr. Mridu, for the kind words, for the kind introduction you gave about me. And a very good afternoon to everyone who have joined in today's session. Before starting my topic, I would like to convey my words of praise to Engineer Amarjit Singh Baliaji for encouraging and supporting our native therapy. And I would also like to thank Principal Dr. Meenakshi Nath and Vice Principal Dr. Mridu Sharma for providing me this platform to share my knowledge. Now, let's start the topic. So, topic for the today is oxygen therapy in children. What is oxygen? Oxygen is a very basic and simple drug. It is most widely used, misused, and overused, even has been abused drug during this pandemic. Everyone can use it, but it is very rarely prescribed judiciously in the developing countries. At ambient temperature and pressure, oxygen atoms bind together to form oxygen molecules that exist as colorless, odorless, and tasteless gas. It makes up 21% of the air by volume. It is a non-flammable gas, but it accelerates the combustion. What is the need of oxygen in our life? As all of us know that two key molecules in our life are glucose and oxygen. Oxygen is required in the aerobic pathway to utilize glucose, which gives 34 to 38 molecules of ATP, which is the energy source for various metabolic activities at the cellular level. Whereas anaerobic pathway gives only 2 molecules of ATP plus lactic acid. So in the absence of the oxygen, cellular death will occur that will lead to the organ failure and multi-organ failure and ultimately death of the patient. And there is no storage of oxygen in our body. Our body needs continuous supply of oxygen. So in short, oxygen is the energy and energy is the life. How we get the oxygen, how oxygen diffuses in our body. Oxygen diffuses along the pressure gradients. First of all, in the atmospheric air, the pressure exerted by the oxygen is 159 millimeter of mercury. And then as we inhale the oxygen, there is humidification, that is adding of the water vapors to the oxygen gas occurs in our respiratory tract, and partial pressure of the oxygen lowers down to 150 mm of Hg. And then it comes to the alveoli, where partial pressure of oxygen further drops down to 100 millimeter of mercury. And from the alveoli, it crosses the alveolo-capillary membrane to enter into the blood. In the blood, the pressure of the oxygen is 80 to 100 mm of Hg. Then blood acts as a vehicle to transport this oxygen to the tissues, where in the tissues it is extracted into the cells and remaining oxygen is further brought down to the lungs level. The pressure exerted in the mitochondria is 7 to 37 millimeter of mercury, and there is one term known as posture point. Posture point is the pressure of the oxygen in the mitochondria below which aerobic respiration will fail and anaerobic respiration will occur. And this is 1 to 2 millimeter of mercury. How the oxygen is uptaken in the body? As I told you, oxygen in the alveoli diffuses across the alveolo-capillary membrane to enter into the blood. In the blood, it is transported mainly in the two forms. The one that is bound with the hemoglobin, rather major percentage, about 98% of the oxygen is bound with the hemoglobin. And this fraction of oxygen that is bound with the hemoglobin, we measure it as a SpO2 by the pulse oximetry. And very small amount of oxygen is dissolved in the plasma. Approximately 2% of the oxygen is dissolved in the plasma, and that we measure by the arterial blood gas analysis, and that is known as PaO2. Now the blood will be acting as a vehicle to carry the oxygen to the tissues, where the oxygen will be released and consumed by the tissues, and rest will come back into the blood. Now what is oxygen therapy? Oxygen therapy is the administration of the oxygen at a concentration greater than that found in the ambient air, that is 21%. More than 21% whenever we give to the patient, this is known as a oxygen therapy. Now, what are the indications for the oxygen therapy? Basically, hypoxemia and hypoxia are the only two indications to treat with oxygen. Now, how do we suspect hypoxemia and hypoxemia? It is suspected by the clinical features, and then it has to be documented by either by the pulse oximeter with SpO2 reading less than 90% or by ABG with PaO2 reading less than 60%. What are the clinical features of hypoxia, or how do we assess hypoxia clinically? There are various symptoms depending upon the system involved. Or in the CNS, mild to moderate symptoms can be restlessness, disorientation, lassitude, headache. And if hypoxia is severe, then there will be somnolence, loss of coordination, obtunded mental status, confusion, impaired judgment. And in the cardiovascular system, there will be tachypnea, mild hypertension, peripheral vasoconstriction. And in severe cases, bradycardia, arrhythmia, and hypertension will occur. In the respiratory system, there will be dyspnea, tachypnea, shallow and labored breathing, and in severe cases, tachypnea and dyspnea will increase, and possibly in the end stages, bradypnea will occur. In the skin, there will be paleness, cold, clammy skin in the initial stages, and in the final stages, there will be cyanosis. This is a diagram showing pulse oximeter. This is the tool that is most valuable tool to detect the hypoxemia. And this diagram shows two readings and one waveform. This is the pulse waveform. First of all, we will look at the waveform. If the waveform is proper, only then we can rely upon the pulse oximeter. There is one reading at the top, that is SpO2 reading. It is 97%, and below which is pulse rate reading. It is 76% in this case. But mind it, the pulse oximeter does not tell us about the ventilation of the patient. So we have to monitor for the respiratory rate of the patient, efforts, and mental status of the patient to look for the ventilation. Otherwise, pulse oximeter will tell us only about the oxygenation of the patient. Next slide. Now, PaO2, that is partial pressure of oxygen, as an indicator for the oxygen therapy. Normal partial pressure of the oxygen is 80 to 100 millimeter of mercury, and between 60 to 80 millimeter of mercury, there will be cold and clammy extremities, and less than 60 millimeter of mercury, cyanosis will appear, and less than 40 millimeter of mercury, mental deficiency, mental loss, memory loss will occur, and less than 30 millimeter of mercury, bradycardia and cardiac arrest will occur. So PaO2 less than 60 millimeter of mercury is taken as a strong indicator for the oxygen therapy. Now, what is hypoxemia and what is hypoxia? Hypoxemia is a low arterial oxygen tension, that is we are measuring with SpO2 level. It can be measured and it is a sign of cardiopulmonary disease. And what is hypoxia? Hypoxia is low oxygen level at the level of the tissues. We cannot measure it directly, and it is a surrogate marker to the organ dysfunction. Now, a patient or a child can have hypoxemia and hypoxia both together, or he can have hypoxemia without hypoxia and hypoxia without hypoxemia. For example, suppose if a patient is anemic with a child with a hemoglobin level of 4 mg%, his hemoglobin will be more than 90% saturated. He will be having a normoxemia, but the oxygen content will be less because the hemoglobin is less. So the tissues will be hypoxic and the patient will feel tired. And the second example we take as a cyanotic congenital heart disease, where there will be compensatory rise in the hemoglobin. Here the SpO2 will be less, that the patient will be hypoxemic, but he will not be hypoxic. Coming to the sources of the oxygen, There are basically three sources of oxygen: the cylinders, concentrators, and central pipeline. Cylinders, as all of us know, that they involve expensive transport and they are source of unreliable supply. And the concentrators, they draw the air from the environment and extract the nitrogen from it, and then they will supply pure oxygen almost 95 to 90%, 99%. They are safe, they are less expensive, they are reliable, they are cost efficient and more convenient. And moreover, they can provide oxygen up to 4 patients at the same time if we apply flow splitters to them. The central pipes line, they supply oxygen at high pressure levels through a system of copper lines from a central source, and they are mainly used to run the ventilators and other high flow machines. Now, what are the oxygen delivery devices? These are the devices that deliver the oxygen to conscious patients with no invasive instrument to their airway. They can be divided into the conventional oxygen therapy that act as ambient pressure, and it is further divided into two forms: variable performance systems, that is low flow systems, and fixed performance systems or high flow systems. Then there is next category that is works under the positive pressure. Here we apply positive pressure to the patients, and in this category we have high flow nasal cannula, or this is also known as heated humidified high flow nasal cannula. Then we have CPAP system, then we have BPAP or BiPAP system. I will be discussing briefly about them in the next slides. What is conventional oxygen therapy? Here the delivered FiO2 will remain fixed or it will vary depending upon the patient's demands. अगर patient की demand change हो रही है, बढ़ रही है, oxygen की supply कम और ज़्यादा हो सकती है. The high flow system, here the system provides all the patient's inspired gas and FiO2 will be stable. जितनी patient की requirement है, सारी की सारी requirement जो है वो system दे रहा है, इसलिए FiO2 जो है वो stable रहेगी. Low flow system में क्या होता है? The patient draws remainder air from the surrounding air and there will be variable FiO2. Low flow system में हम basically एक fix amount का उसको दे रहे हैं, जो remainder उसकी air है वो patient environment से draw कर रहा है, तो FiO2 will vary. More the minute ventilation of the patient, lower will be the FiO2. I will give you an example of this. Now suppose there is one patient who is not in any respiratory distress, or he is having a mild respiratory distress. His minute ventilation is 5 liters per minute. He is breathing at a rate of 10 breaths per minute and his tidal volume is 500 ml. So minute ventilation comes out to be 5 liters per minute. Now in the low flow system, suppose we are giving him oxygen at the rate of 2 liters per minute. Now his requirement is 5 liters per minute. He will draw 3 liters per minute from the air. Now if we calculate his FiO2, that is percentage of oxygen but he is taking, it comes out to be about 53%. Now the same patient, when his condition has deteriorated, he has developed respiratory distress, his minute ventilation has increased. Now he needs 30 liters per minute if he is breathing at 40 breaths per minute and with a tidal volume of 750 ml. He is the same patient, mind it. And the oxygen flow rate we are giving him is 2 liters per minute. Now he will need to get 30 liters. He will draw 28 liters per minute air. He will draw it from the atmosphere. Now his FiO2 will come out to be 0.26 or 26%. So in nutshell, what I want to say that if respiratory distress of the patient is increasing, we are giving oxygen by the low flow devices. Then with the increase in the respiratory distress, we will be giving less and less oxygen to the patient and the patient will deteriorate. What are the common oxygen delivery methods? That is low flow oxygen devices. Commonly we use nasal cannula, nasal and nasopharyngeal catheters, simple face mask, partial rebreathing mask and non-rebreathing mask. These are the low flow systems. That is, they will be providing variable FiO2 to the patient. Now, what are the nasal prongs? These are the two soft prongs that are attached to the oxygen tubing. They are the most of the time they are preferred source to give oxygen. and they are available in the different sizes and different shapes. And don't fit the nasal prong snugly into the nares. Mind it, इनको snugly fit नहीं करना है जब भी हमने apply करना है, बिल्कुल tightly fit नहीं करना है nares में. I will tell you the device where we fit them tightly in the next slide. And the size of the prong depends upon the patient age, nares size, and width of the nasal bridge. They are available in the neonatal, infant, child, and adult sizes, and they can be size can vary from 1 mm to 2 mm to 3 mm to 4 mm, and they are in the different shapes, like they can be curved in shape or flared shape or combination of these, or they can be straight prongs. What are the merits and demerits of them? Merits: they are easy to fix, they are simple, they are lightweight. There is not so much interference with the airway, no interference with the feeding. They are low cost, they are compliant, they are better tolerated, and they are ideal for the long-term oxygen therapy. What are the demerits? They can be easily dislodged. We cannot provide high flow rates with them. They are very uncomfortable for the high flow rates. They can induce nasal trauma. Mucosal irritation can occur, drying, epistaxis, ear tenderness. And as I have already told you, they provide they are low flow devices. So the FiO to deliver with them will be inaccurate and inconsistent. Now the standard recommended flow rate for the nasal prongs are 0.5 to 1 liter per minute for the neonates, 1 to 2 LPM for the infants, and 1 to 4 LPM for the children. Generally, the delivered FiO2 will increase by 4% per liter of the oxygen flow. That is, if we are giving flow rate 1, 2, 3, 4, 5, 6 liter per minute, the FiO2 will be 0.24% for the 1 liter, 0.28%, 0.28 for the 2 liter per minute, 0.32 for the 4 liter per minute, and 0.40 for the 5 liter per minute, and 0.44% for the 6 liter per minute. Then this rate is applicable only when the patient is taking he is on normal ventilator pattern. Now the next device is nasal catheter. This is a single lumen catheter placed into the anterior nares. Recommended oxygen flow rate here is 0.5 to 2 liter per minute, and FiO2 delivered is 35 to 40%. They should be avoided in a suspected nasal mucosal tear, and there is no specific advantage over the nasal cannula. They can get easily blocked with the mucus, and aspiration and gastric distension can occur if they are placed into the esophagus. And then nasal catheter, how much distance should we insert them? The distance is from the side of the nostril to the inner margin of the eyebrow. The tip of this catheter should not be visible below the uvula, and the appropriate size is for the neonates and infants it should be of 8 French, and for the older children it should be of 10 French. Now the next device is nasopharyngeal catheter. Again, this is a single lumen catheter which is lodged into the pharynx by the nostrils, and it is inserted to lie down just below the uvula. जो nasal catheter था उसको हमने uvula के ऊपर रखा था, but जो nasopharyngeal catheter है, as the name implies, it is in the pharynx, so it has to lie below the tip of it has to lie below the uvula. The recommended oxygen flow again here is 0.5 to 2 liter per minute. It can achieve higher FiO2 at low oxygen flow rate, and it also generates some PEEP in the trachea because of its position. And the nasopharyngeal catheter requires external humidification as it is passing the natural humidifying and warming properties of the nose. क्योंकि नोज को bypass कर रहा है, इसलिए humidification इसके लिए जरूरी बन जाती है. It can get blocked with the mucus, and it is difficult to insert. It may provoke gagging, and aspiration and gastric distension can occur if it is placed into the esophagus, and it always requires external humidification. Now, what should be the distance nasopharyngeal catheter to be inserted is 1 centimeter less than the distance from the side of the nostril to the front of the ear. Tragus. This distance is 1 centimeter कम. Tip of the catheter should be visible just below the uvula, as I already told you. The appropriate size for the neonates and infants it is 8 French, and for the older children it is 10 French. Now the next system is the reservoir mask. there are three or basically four types of reservoir mask. The simple face mask, or also known as a rebreathing mask, partial rebreathing mask, and non-rebreathing mask. Simple face mask, all of us know it is a transparent mask with two side holes, and the mask itself acts as a reservoir, and its capacity is only 100 to 200 ml. Minimum flow rate of 5 liter is required to prevent the carbon dioxide rebreathing, and a flow rate of more than 8 liter per minute will not increase the FiO2. The FiO2 provided by this device is 0.4 to 0.6%. Now, what are the demerits and merits of simple face mask? Merits: it is good for the patients with blocked nasal passages and mouth breathers, and it is easy to apply, and it can be attached to the reservoirs, and then it will provide the higher FiO2. Demerits: it is uncomfortable, it will interfere with the further airway care, drinking, speaking, and eating. Proper fitting and seal is required with the face mask, and there is always a chance of rebreathing and carbon dioxide retention. Now, what is partial rebreathing mask? Partial rebreathing mask is a simple mask to which we have attached the reservoir bag. There are no valves in this bag, in this mask. Now, this is not so much used, but it is useful in certain situations when we have a limited source of oxygen. The FiO2 delivered by it is varies from the 0.6 to 0.8%, and here a minimum flow rate of 8 liter per minute should be given to prevent the exhaled carbon dioxide to re-enter into the body and to refill the oxygen reservoir. How does it work? During expiration, oxygen flows directly into the reservoir bag along with the first 1/3 of the exhaled gases. जब हम एक्सहेल कर रहे हैं तो उसकी 1/3 जो गैसेज है वो रिजर्वायर बैग में जा रही हैं, और जो इनपुट दिया हुआ ऑक्सीजन का वो भी साथ में आ रहा है, और जब इंस्पायर कर रहे हैं इसको, द मिक्सचर ऑफ गैसेज 1/3 of the expired gases and the remaining oxygen we are inhaling. So this is not going to give 100% of the oxygen. Now this is a diagram showing a simple face mask, and this is a, जब मास्क के साथ हमने रिजर्वायर अटैच कर दिया, then it becomes partial rebreathing mask. Here I tell you 100% of the oxygen is coming, and it is getting mixed with the expiratory gases. Only 1/3 of the expiratory gases, when the patient is expiring, only 1/3 of the gases are coming into the reservoir bag. The rest of the expiratory gases are coming out through these exhalation ports. What are the advantages and disadvantages of this mask? The inspired gas does not mix with the room air. Patient can breathe room air through the exhalation ports if the oxygen supply is, gets stopped or interrupted. And disadvantages: more oxygen flow does not increase the FiO2. It interferes with the drinking and eating. Now comes the next, rebreathing mask. Here the mask, this system has 3 unidirectional valves. इसमें 3 valve लगे हुए हैं, जबकि जो partial type का बैग था उसमें कोई valve नहीं था. Here you can see in the diagram, one valve is here at the junction of the mask with the reservoir system, and 2 valves, unidirectional valves, are here at the exhalation ports. When we are attaching it with the oxygen, 100% oxygen is coming and through this valve, and when patient is exhaling, the exhaled air cannot enter into the reservoir bag. Instead, exhaled air will be coming out through these exhalation ports. So this will be giving us more FiO2, and the FiO2 given by this mask will vary from 0.8 to 0.9%. But mind it, minimum flow required to maintain this FiO2 will be 10 to 15 liter per minute. Otherwise, if we are not giving flow, this much flow, or we are giving less than 10 liter flow to the patient, there will be carbon dioxide retention in this mask, because there is only unidirectional valve. So carbon dioxide जो अंदर इकट्ठी हो जाएगी, and the patient will be going into hypercapnic type of respiratory failure, type 2 type of respiratory failure. So this mask we are using only in the emergency situation and when the patient is severely ill. And the advantages: this is highest possible FiO2 that we can give without intubation with this mask, and this is suitable for the spontaneously breathing patient with severe hypoxia. What are the disadvantages? This is expensive mask. One mask costs about 700 to 800 rupees, and it requires tight seal, and this is uncomfortable to the patient. It again interferes with the drinking and eating. This is not suitable for the long-term use. Malfunction of this can cause carbon dioxide buildup and suffocation to the patient. And next comes the enclosure devices. They are not used so frequently, like the oxygen hood. It covers the oxygen. It covers the head of the infant. Minimum flow rate required with this device will be 10 liter per minute or 2 to 3 liter per kg per minute to prevent the carbon dioxide accumulation. There is lot of wastage of the oxygen with this device, and this is difficult to clean, and it limits the patient mobility. Not so much used in today's practice. Next comes the high flow devices or the fixed performance system. Here the FiO2 delivered by the system will be independent of the patient factor. Patient की minute ventilation कम है ज़्यादा है whatsoever it is, but the system is going to provide a fixed FiO2. These are the Venturi type of masks. They basically work on the principle of Bernoulli's theory. What is Bernoulli's theory? That oxygen, when oxygen passes through a small orifice, it entrains the air to a very predictable dilution. जब ऑक्सीजन को हम एक नैरो ओरिफिस से ऑक्सीजन को हाई वेलोसिटी से पास करती है तो उसके सराउंडिंग में अपर्चर होते हैं, एज यू कैन सी इन द डायग्राम बिलो. सराउंडिंग अपर्चर से इन ए वेरी फिक्स्ड एंड प्रेडिक्टेबल मैनर में एयर आती है, तो उससे जो FiO2 है दैट रिमेन वेरी कांस्टेंट. इट कैन नॉट चेंज विद द चेंजिंग डिमांड्स ऑफ द पेशेंट. The FiO2 is adjusted by changing the Venturi value and setting the oxygen flow rate. As I have shown in these diagrams, these are the oxygen or Venturi. These are known as Venturi adapters. They come in the different colors. There are 5 to 6 colors for the adapters, and each adapter is written with the oxygen flow rate in the liters per minute and FiO2 it is going to provide. Now, these are the types. The blue adapter, when we are giving a flow rate of 2 to 4 liter per minute, is going to provide us 24% of oxygen. And with the white one, when we will be giving 4 to 6 liter per minute, and it is going to provide us 28% of oxygen. With the yellow one, we are giving 8 to 10 liter per minute, and it is going to provide 35% of oxygen. The red one is going to provide 40% at 10 to 12 LPM, and green one is going to provide 60% oxygen at 12 to 15 LPM. So basically, these Venturi masks we use where we require very precise amount of FiO2, and precise and minimum amount of FiO2 is required. These are used basically in neuromuscular diseases where the hypoxic drive of the patients is gone, like COPD. In the COPD cases, इसमें क्या होता है कि पेशेंट COPD केसेज या न्यूरोमस्कुलर डिजीज जो है, पेशेंट ऑलरेडी इन टाइप 2 रेस्पिरेटरी फेलियर, दैट इज हाइपरकैप्निक रेस्पिरेटरी फेलियर में होता है. इनकी ऑक्सीजन ज़्यादा कार्बन डाइऑक्साइड बॉडी में ज़्यादा होती है, तो इनको रेस्पिरेटरी ड्राइव रखने के लिए हम थोड़ा सा हाइपोक्सिक रखते हैं, थोड़ी सी इनकी बॉडी में ऑक्सीजन की कमी रखते हैं. डेलिबरेटली इनकी FiO2 हम और SpO2 कम रखते हैं, तो उसको कम रखने के लिए हम इनको कम FiO2 देनी पड़ती है. इसलिए दे आर वेरी यूजफुल इन COPD एंड न्यूरोमस्कुलर डिजीज, अदरवाइज दे आर नॉट यूज्ड रूटीनली. तो नेक्स्ट comes the high flow nasal oxygen. This is better known as heated humidified high flow system. These systems are very much in fashion nowadays in the pediatric practice, but this system is the oxygen and air comes from the ball source or from the source, and they are mixed and they are blended by a blender. Then they are coming through the flow meter, and after the flow meter there is a humidifier. Here the gaseous mixture of air and oxygen is heated and it is humidified. It is heated to a temperature of around 37 to 39 degree. Then comes the inspiratory limb, and through the inspiratory limb there is a cannula, and this is this cannula is going to be attached with the patient. So this system is going to give a very high flow up to 60 liter per minute to the patient, and that this much high flow is going to provide PEEP to the positive and expirative pressure to the patient. I hope I am not boring you people. And the technique for high flow nasal cannula is fit the nasal prongs, initiate the maximum flow, place the surgical mask to reduce the aerosol dispersion. This is very important nowadays during the COVID area. When we have placed the nasal cannula in the nari and above the nasal cannula, we have to place the surgical mask. Any device we are using, we have to use the surgical mask over that device to reduce the aerosol dispersion. Then we set the FiO2 as per the oxygen required for the patient, and then we can heat the gases to 37-degree temperature to start with, and then we come down to 34-degree centigrade. Next is the non-invasive ventilation. These are basically CPAP 2 devices here. I am going to show you the CPAP, that is the name implies continuous positive airway pressure, and then the BiPAP, that is bi-level BiPAP, by positive airway pressure. Here we are going to give two pressures to the patient. These are the pressure devices. जो अब तक लो फ्लो डिवाइसेज हमने डिस्कस की थी, उसमें हम एम्बिएंट प्रेशर के ऊपर काम कर रहे थे, but these are the high pressure devices. Here we are going to provide the gases to the patient at a pressure level. We are going to give pressure to the gases so they can reach the patient level, patient alveoli level. Now this is a diagram showing the normal breathing. Normal breathing, patient is breathing normally, inspiration, and then he is expiring. And then this is the CPAP, continuous positive airway pressure. Here what we have done is we are giving continuously, we are giving this much pressure to the patient, continuous pressure to the respiratory system of the patient. Above this pressure, patient is breathing normally. Okay, and then the second is bi-level pressure. Here we are giving two pressure to the patient. The one is again expiratory pressure. This is expiratory pressure. यहाँ हमने इसको CPAP बोला था, यहाँ हम इसको EPAP बोल रहे हैं. The pressure is the same, EPAP and CPAP. This is a continuous pressure applied to the system. And then the other pressure is IPAP. Here this much pressure is we are applying to the during the inspiratory phase. This is inspiratory positive air pressure. This is expiratory airway pressure. ये हमने expiration के टाइम दिया है और ये हमने inspiration के टाइम दिया हुआ. Now the next system is bubble CPAP. This is the diagram showing what is bubble CPAP. Here we are, as I have already told you, here we are providing a continuous positive airway pressure. This is the system. Here the oxygen and the air, they are blended. Then through the flow meter, we are setting the flow, how much flow we want to give to the patient, and the gases are coming out of flow meter. And this is the humidifier. Here the gases will be humidified and they will be heated. And then this is the inspiratory limb. The gases are coming to the patient. Here we have applied the nasal cannula to the patient and to the nares of the patient. And mind it, in the CPAP system, the cannula we are putting in the nasal cavity, they have to be snugly fitting into the cavity. यहाँ पे हम बिल्कुल tightly fit करते हैं उसको ताकि बिल्कुल भी उससे कोई लीकेज ना हो कोई और बॉडी में, because we have to give the pressure to the patient. Pressure की कोई लीकेज नहीं होनी चाहिए. And the second reason is here we are giving the expiratory limb. ये expiratory limb में है हमने pressure apply किया हुआ है. यहाँ हमने ये water system है, इसके अंदर जो expiratory limb है इसको हमने रखा हुआ है. जितना इसके अंदर वाटर में ये एक्सपिरेटरी लिम्ब होगा, जितने सेंटीमीटर होगा उतने सेंटीमीटर का प्रेशर जो है वो उसको एल्वियोलाई पे जाएगा. उतने सेंटीमीटर का प्रेशर से पेशेंट के जो एल्वियोलाई है दे विल रिमेन ओपन, and this will provide the FRC to the patient. This is known as functional residual capacity, at which gas exchange will occur continuously to the patient. जैसे कि एक गुब्बारा होता है, हम गुब्बारे को इन्फ्लेट करते हैं, तो जब शुरू में गुब्बारा है वो एक डिफ्लेटेड है और उसमें से अगर हम चाहें तो उसमें से गैस एक्सचेंज नहीं हो पाएगी. जब हम उसको थोड़ा सा इन्फ्लेट कर देंगे, थोड़ा सा बड़ा साइज में हो जाएगा, तो उससे इजीली गैस इन्फ्लेट होती रहेगी. तो सेम इज द सिस्टम हियर. जो एल्वियोलाई है हमने उनको कुछ प्रेशर देके उसको इन्फ्लेट करके रखा हुआ है थ्रू आउट द रेस्पिरेशन. अब उससे जो गैस एक्सचेंजेज है वो इजीली होती रहेंगी. Now this is a slide showing in nutshell what I have discussed. different devices and the flow rate given with them, the FiO2 given with them. Now, coming to how we are going to attach the oxygen devices to the patient. First of all, we are going to perform the hand hygiene, and then donning, we will wear the PPE kits, and we will explain the procedure to the child and family, and then we will ensure that they agree to the treatment, and then place the selected oxygen device on the infant or child. If one method of oxygen delivery upsets the child, then we can change it to another method, and then we will adjust the flow meter to deliver the desired amount of the oxygen, ensure that liter flow is appropriate for the device. This is very important. The LPM, liters per minute, the flow we are giving, it should be appropriate for the device. And then we apply the oxygen delivery device, and then we discard the supply, we remove the PP kits, and then we again perform the hand hygiene, and then we document the whole procedure in the record sheet. Now, when we have attached the patient to the oxygen delivery devices, and they should be applied and secured, and ensuring that it is the correct size, हमें ensure करना है वो size correct होना चाहिए, और rational क्या है, the correct size device will ensure the optimal delivery of the prescribed oxygen, and it will reduce the risk of skin breakdown. And suppose if we are using a mask, and then ensure that it covers the mouth and nose of the patient, but it should not cover the eyes, and we should use the adhesives to secure the nasal cannula, or we should use the elastic strap for a face mask. And then we should evaluate the child oxygen delivery device for proper fit. Ensure that nasal cannula prongs remains in the nares, they does not snugly fit, and ensure that the patient's patient's head remain in the oxygen hood. Then how we should care the child who is on oxygen. This child must be supervised by the trained staff. Mind it, it should be a trained staff, and check every 3 hourly that prongs are in the correct position. They should not be blocked with the mucus. The connections are secure. Oxygen flow rate is correct. Airways are patent. There is no gastric distension. Remove and clean the prongs at least twice daily. Assess the skin for any breakdown. Look for any dried secretions and provide humidification if necessary, and clean the humidification chamber daily. Now, how we are going to monitor a child who is on oxygen? We will be monitoring again the same parameters which were the indications. Now they have become the monitoring. We will monitor the clinically patient for the clinical features of the hypoxia, and with the pulse oximetry and with the AVG. Now, how much oxygen is safe? 100%. We should not use 100% oxygen for not more than 12 hours, 80% oxygen for not more than 24 hours, and 60% oxygen for not more than 36 hours. Now, documentation. Whatsoever procedure we are doing, we should document in the patient records. We should document the delivery device and what amount of oxygen we are delivering. We should document the respiratory status, including the work of breathing and breath sounds, vital signs, pulse rate, SpO2 reading, capillary perfusion, and response of the child to the supplemental oxygen should also be documented. Pain assessment and related intervention should be documented. Any undesired outcomes, including mental status deterioration. This is very important. Mental status deterioration of the mental status of the patient should always be looked into. This is important because suppose if we are not giving flow that is required for that device, that will lead to buildup of the carbon dioxide in the device, and that will lead to carbon dioxide retention in the body, and patient will deteriorate. He will become lethargic, and he can perspire, and ultimately he can die. And we should always take the consent from the family and educate them about the oxygen therapy. And now, complications. As all of us know that every drug is associated with complications, or no drug is without any complication. So same is the case for oxygen also. It can lead to the acute pulmonary toxicity like cough, laryngotracheitis, chest pain, or even ARDS like features. जिन कंडीशंस के लिए हम ऑक्सीजन को दे रहे थे, अगर हम इसका प्रॉपरली यूज नहीं कर रहे हैं या ज़्यादा FiO2 दे रहे हैं, द सेम कॉम्प्लिकेशन इट कैन लीड टू. Then it can lead to the depression of the ventilation or hypoxic drive in the neuromuscular disorders. I have already told you. In the low birth weight babies or premature babies, it can lead to retinopathy of prematurity. And then it can also lead to the absorption atelectasis at high FiO2. And of course, there will always be a risk of fire whenever we are giving oxygen. Now, when to stop the oxygen? When the child is hemodynamically stable and his SpO2 remains stable, that is more than 90%, then a trial of room air can be given for 15 minutes, and preferably this trial should be given in the morning hours when we have sufficient number of staff to care to supervise the child. And when we have given the room trial or we have disconnected the child from the oxygen, now we have to carefully observe the child for any changes in his clinical signs and SpO2. Now, if the SpO2 of the child remains more than 90% on the room air and there is no clinical deterioration, then we can recheck the SpO2 after every 1 hour. When the SpO2 of the child remains more than 90% on the room air for more than 24 hours and there is no danger sign, then the child can be discharged. Now, one important point is that the chest X-ray has no role. Chest X-ray has no role neither in initiating the oxygen therapy nor at the time of stopping the oxygen therapy. It is only the SpO2 level and the clinical indicators that have the role. So take home message. Oxygen is a very precious resource to be used judiciously and efficiently, and it should be used for the right indication, right dose, right device, right duration, and we have to monitor for the dangers and complications, and we have to monitor for the need of oxygen therapy on the periodic basis. And knowledge and identification of the oxygen delivery systems are very important. Common oxygen delivery systems are nasal prongs, nasal nasopharyngeal catheters, rebreathing and non-rebreathing masks. Nasal prongs are the preferred oxygen delivery method in most of the circumstances. Humidification is essential when cold oxygen is delivered from a cylinder through a nasopharyngeal catheter or when high oxygen flows are used. And humidifier reservoirs should be cleaned regularly to avoid any bacterial contamination. Now, in nutshell, oxygen is an essential drug. When appropriately used, it is extremely beneficial, and when misused, it is potentially harmful. So this was all from my side. Thanks for listening me so patiently, and I hope I have done justice to my topic. Thank you, Dr. Mridu and Dr. Ajay, Dr. Meenakshi.
Thank you, sir. Thank you for this wonderful presentation. Today, and especially many pediatric topics like respiratory distress and neonatal resuscitation were covered. Hope our students have learned a lot. Thank you, sir. Thanks a lot.
Thank you.
So this we conclude our today's session. Thank you. Thank you, everyone.
हेलो। ओ करता है।